My first response when I got this question was, well, we tested, but obviously we might want some more information than that. So hopefully I can add to that, and I will be able to gloss over a few things so that we don't repeat ourselves. So I'm going to talk a little bit about these things, why we need a vaccine, and the possibility of protective immunity. And I'm going to add to some of what Chris just discussed by showing you some human data. Some of the challenges that we have in showing that this works, how we're going to overcome these, and then I'll tell you a little bit about the trial that's underway. So we know we have all these great therapies, and they can cure pretty much anyone, but it's very expensive, it's out of reach, it doesn't reverse disease. And we really don't know yet if it provides protection against reinfection, especially in populations who are at high risk. I will tell you, too, that finding the people who need treatment still remains challenging. Maybe not baby boomers, but places where the infection is focused. In most places, they don't know, most people don't know their infection status. In the US, this is 50% or lower compared to HIV, which is about 80% of people who know. And in places where there is now aggressive screening, we have a lot more people aware, but it still falls short. So getting those people is hard. I don't believe that we can have any kind of eradication program for hepatitis C unless we work with the people who have the highest bolus of infection, and that's mostly, in most areas, people who inject drugs. But they really don't, a lot of them don't know they're infected, and they don't test, or they're tested only for anti-HCV. They're not evaluated for treatment, they're not offered treatment, and they don't complete treatment. But we know that there's data that shows that they can complete treatment if you give it to them and if you offer it in a way that works. So we still have a lot of work to do there. In other endemic regions of the world, we have other reasons besides injection drug use that account for high prevalence, including limited access to testing and both iatrogenic infection and limited access to therapies. And I'm thrilled that this is happening. Eradication efforts in Georgia and Mongolia, and I'm challenging John Ward to help me do that in New Mexico. We also need to treat people for other reasons. So there are these host protective immune responses that give us hope that we can create a vaccine that will work. And there are some basic factors that really show who clears it. So what, of those 25% of people who clear the virus, who's clearing the virus? This is from a paper that Jason Grebley wrote from a study that I've put together with colleagues from many other countries. That's called the International Collaboration of Incident HIV and Hep C in Injecting Populations. And we've merged data from 10 cohort studies, and so we're able to look at some of these events that happen. You know, I have 100 people who get infection, but only 25 of them will clear, and then how many of those get reinfection? We have small numbers, so the INC3 group has put together this big collaboration, and what you can see here is that basically women clear more than men. Interferon lambda 4 genotype CC clears more than anyone else also. And there is a viral factor that appears to be effective too, which is that more people will clear genotype 1. But let's talk about these host factors. This is also from INC3, and you can see that a very large proportion, 50% of women who are CC positive will clear, compared to about 26 and 29% of males and females who are non-CC positive. Women, even if you don't know their interferon lambda 4 genotype, have a 3 times higher likelihood of clearing than men. And there is still not enough work being done in understanding why women clear more than men. So another challenge out there for folks. This is the same data just showing a survival curve, but women, twice as many women will clear who are CC positive than men who are CC positive. So we still have a lot to learn there. Obviously, we have all these other T-cell responses, which Chris Walker reviewed, and many of these now have been shown in humans. So let's talk about the protective immune response, and I was really glad you didn't present all the human data because I get to do that. So the first reinfection happens, but protective immunity really is not apparent, it's not a given, but there is some evidence that suggests that it happens. So this is data from many cohorts across the world that have looked at both primary and, here's a little thingy. Primary and secondary infection, and you can see the rates of spontaneous clearance in these different cohorts. This is in Baltimore, this is in San Francisco, in Melbourne, in Amsterdam, and this is Vancouver data, and you can see that in general we have about 25% of people who clear, and here's the reclearance proportions. As low as 29% from data in Vancouver and as high as 83% from the Baltimore study. But notice here, these are these N's, right? So I'm an epidemiologist, and an N of 10 is just not enough. And so again, we have INC3 data where we were able to merge a lot of this data and look at this in multiple cohorts. And what you can see is in a larger number of people, we have an average of 52% of people who re-clear after being reinfected. So this makes sense. These boundaries are informed by or misinformed by many things, including testing frequency. If you test someone every month after they've cleared an infection, you're more likely to find a reinfection than if you test them every 6 months. But this data clearly shows that about at least half of people will re-clear their infection following clearance. And this is the same data that he showed from Bill Osborne's lab, which shows subsequent infection and lower viremia, and also the lower duration. Rachel Sachs-Davis took the INC3 data and analyzed this in our big pool of studies, and what you see is that the median time to spontaneous clearance, I guess I should back up. There's about a 1.7 log difference between primary infection, peak viremia, and subsequent viremia that she also showed in that paper published in JID. So the peak viremia goes from about 6 something down to 4 something, and don't have that in front of me. But the time to clearance in humans is a little bit different from chimpanzees. It's about 5.5 months for the first infection, and this is dependent on observation time, and 3.2 months in humans who are subsequently infected. So there's a difference of about 2 months. And that T-cell response broadens during the reinfection, which is largely probably accounts for why people keep clearing. And they keep clearing and clearing. I have participants, and my colleagues have participants who have been reinfected and re-cleared 4, 5, 6 times. It happens twice, 3 times. They just keep re-clearing. We call them our super controllers. They have these recurrent detectable viremic events. There is data now suggesting maybe antibody responses do come into play there, and they develop these long-lived memory T cells. So we won't talk about the vaccines in development because we just got a great talk about that. But we still have a lot to learn about what is the effective immune response, so there's still a lot. Making a vaccine is really challenging. It's a highly diverse virus. We're not using killed or live attenuated viruses. And this interest in inducing T-cell responses, the idea is to mimic that same response that we see in people who clear. I'm reading this book right now, how the atomic bomb was made. And Ernest Rutherford has this quote that, science isn't really a big discovery if you can't explain it to a barmaid. And I have to explain this stuff to people who are in a vaccine trial. So I try to do it really simply. So we tell people about immune responses, and we have these candidates, which right now is focused on using vectors to deliver these viral antigens. And I talk about it like in the movies, like that Bourne movie. We're trying to deliver the virus like it's in a little suitcase. Remember that movie? That's my talk to my subjects. So we put this virus, we pack it in a little suitcase that your body recognizes. These are those vaccine strategies that Chris discovered or discussed. So let's talk about why we are using this particular vector in the Okairos /GSK vaccine. They went, Okairos decided to search for these adenoviral strains in non-human primates. The idea was to find something that that humans hadn't been exposed to, so that they could have an immune response. And they discovered these adenoviral vectors from these chimpanzees that are highly immunogenic, are easily to manufacture, and they don't have cross-reactivity in humans. Very few humans have seen this virus before, so there's very little cross-reactivity. And you saw the data from the chimpanzees. They differ, and they're highly immunogenic in the animal studies. They tested basically the chimp AD3 and AD6, and they then added an MVA attenuated strain, and they made this vectored vaccine. And we pretty much love describing why we are testing a smut vaccine in our subjects. But basically, we've packed pieces of the protein from the virus onto this little chimp advirus suitcase, and we are delivering it to people. The idea is to induce the antiviral immunity with functional characteristics analogous to those that we see in spontaneous resolution, and have these broad, targeted, functional CD4, CD8 T cell responses. That data from the 2014 Clinical and Translational Science paper is just really, we were all thrilled with it. It's just amazing, and I can't show it enough that we have these very high, when you give people the MVA boost, the little triangles, you see this big vaccine, this T cell response in these groups. And really importantly, because this vaccine is made with a type 1b virus antigen, we are seeing this cross-reactivity response, which also made us happy. But the truth is, we don't really know what the immune correlates of protection are. Is it enough to have this much, or do we have to have this much? We're going to be finding out. So the VIP study is being conducted in several places. Johns Hopkins, led by Andrea Cox. I started the trial in San Francisco, even though in the program it says I'm from UCSF. I'm not. I was, but now I'm from University of New Mexico. And we started the trial there, and now we've opened a third site in Albuquerque at University of New Mexico. The population we're testing the vaccine in is 18 to 45-year-olds who are active injection drug users. They have to have been injected in the last 3 months. And they're not infected with HCV RNA or antibody at screening. And we're also excluding people who are at high risk for HIV. I'll take a question on that later. The total size of the sample in the initial, when we started this, was going to be about 350 people, and it's been up to about 450 people. And the goal is to assess safety, the induction of immune responses, and a primary outcome is efficacy in preventing chronic infection. We do have secondary outcomes that we're studying, which include, is there cross-protection against different, is there better or lesser cross-protection against different genotypes? We have a lot of type 3 virus in our injecting populations. And also, does it potentially prevent primary infection from establishing also? And we have some other secondary, but these are the primary ones: safety, immunogenicity, and efficacy. So what we're doing in this design is we administer 2 vaccines at week 0 and 8. The first vaccine is the chimp smut virus, and the second one is the MVA boost at 8 weeks, and we assessed immune responses. We take a lot of blood at all of these time points. The trial was designed in 2 stages. In the first stage, which was completed quite early, we had an early safety and immunogenicity assessment to see if we were seeing immune responses, because if we weren't in our population and they're active injection drug users, then it probably would have gotten canceled, but we were. That was all blinded, and so we got to keep going and keep recruiting and keep screening. We test for HCV RNA monthly. after the vaccine is administered, we have people assess the injection site. They come in every 2 or 3 days for a couple of weeks, and then we have monthly visits where we test for HCV RNA. We don't test for antibodies. The vaccine in early human trials did elicit a vaccine-induced antibody response in about 10% of subjects. Note that that's 10% of 30. So we really don't know what that will look like in this group, but because they want to keep me blinded, I don't get to look at antibody responses. The participants are followed for 20 months following the first vaccine. If they become viremic, they're followed for 9 months after the virus is detected. So if you are detected, and we have had people who show up with infection on the last day that they're supposed to be in the trial, and so then their whole participation can be 29 months as opposed to 20. So what are some of the challenges here? Well, we need a population at risk. We have to have people who have high incidence in order to test a vaccine, in order for it to be cost effective, and people who inject drugs have the highest incidence. But we could certainly be testing the vaccine in HIV positive MSM, healthcare workers, perhaps incarcerated. These are some other potential target populations. People living in locales with endemic Hep C and elevated risk, usually ascribed to iatrogenic exposures. People treated for Hep C and who may be at risk for reinfection. And we should be looking at another group for whom there is no prevention whatsoever, and that's children born to HCV positive mothers. But here's some of the challenges. It takes a lot of people. So even in our injection drug user population, where we have an incidence in San Francisco of 25 per 100 person years, so 25% infection rate in a community observed sample. This is data from Bethany White in Sydney, and she calculated, well, how many people it would take to test a vaccine with different efficacies by population incidence and rate of infection. And this is, the sample size estimations for conducting a trial like this actually aren't based on the incidence of infection, it's based on the incidence of chronic infection, because that's what we're trying to prevent. And so it's a little tricky. I had a lot of fun doing sample size calculations when we started the trial. And incidence in Sydney is much lower than it is in San Francisco and in Baltimore and Albuquerque. But if you have an incidence of 6% or 12% and a vaccine efficacy where you want to detect a hazard ratio of 0.4, so you want a 60% effective vaccine, you have to have between 466 and 900 people. And we are powering this trial to detect a 60% efficacy. The VIP trial is powered for that. So depending on what you have in your area, obviously impacts the number of people. But guess what? It's bigger than that. The study design in a vaccine trial is generally an according to protocol analysis. So we analyze people who took the medication according to how it was prescribed. ITT is a secondary approach in this. And so these are the things that impact your sample size, retention, and with our group who are active injection drug users, we have a lot of loss, incarceration, death, and dropout. And then something I never even thought of, doing those fancy sample size calculations, people got infected between their first and second vaccine, which actually makes them not evaluable in the according to protocol analysis. They're evaluable in the ITT, but not the ATP. So I love science, so this has been really fun. But a lot of things happen, and so hence our sample size grows. The design of a vaccine trial in any of these populations is also really challenging. We have to have best practice prevention, which includes referrals to drug treatment, sterile injecting equipment, counseling to reduce and or eliminate risk, referrals to care and treatment, and then a lot of safety issues. So in San Francisco, we have succeeded in referring 30% of our patients to medically assisted opiate therapy treatment, which is higher than I've ever accomplished in my observational studies. And we know that opiate substitution treatment really reduces incidence of Hep C. So there goes your sample size, right? Those are things that we didn't think of. We're going to do the most that we can to prevent Hep C, and we can do it. There's a lot of tools out there to help prevent it in addition to treatment and in addition to vaccine. So we need to be using all of those. What do we want in a vaccine? This is also challenging because we need to have efficacy. We want something that's actually going to have some impact that will either slow or halt disease. It needs to be safe for all ages. It needs to be effective for immunosuppressed persons, give her long-term protection. And so these are all the things that we want. We're definitely not there. We're testing the first trial ever. What we can hope for is that it won't be the last. There's a lot of mathematical models. People love mathematical models. It's a really quick way to look at science without really going into the field. So we did this model some years ago about the potential impact of a Hep C vaccine in people who inject drugs. And basically we found that this was back when we thought it was going to be a 3-dose vaccine, and it turned into a 2-dose. So that actually impacts adherence and retention. But in the best case scenario with 80% efficacy and vaccinating 1% per month, we can go from HCV incidence at baseline of 13.5% to 3.2%. And that's in 10 years. In the same thing, if I go from 25% down to 5%, it's like 30 years. So there's a lot of things that impact how well a vaccine will work. Another model was done here in Canada, which actually looked at risk-based delivery as well as a general sort of school-based platform delivery. And they both work, and they are both very cost-effective. And most recently, there's a new model was recently developed. Margaret Hellard and her group actually looked at whether vaccinating people who were treated, vaccinating the same number of people. See the little blue part there. They wanted to look at whether it's a deterministic model, HCV prevalence, and looking at different scenarios of providing vaccination to people who are treated, people who are vaccinated after treatment, and then vaccinating anyone else who's not infected. The sort of take-home message from this model was that vaccinating people, we can eradicate virus without treating people who inject drugs. We can't eradicate virus without treating people who inject drugs. But the biggest impact of vaccination is in areas where you have the highest prevalence of infection. So looking at the 3 scenarios, you actually drive down prevalence the highest in the people who have the highest chronic prevalence. And this paper was just published in BMC Med. I kind of bungled that up, but Margaret can talk about it better. So we know that we need a vaccine. We know that protective immunity exists in vivo. As with HIV, it's not going to be easy, and I just hope that we can get the same amount of resources to keep going. And we have a trial that's underway, and hopefully we'll have the results. Well, we will have them in 2016, we think. So how do we prove it works? I'm sort of back to the beginning here, which is, well, we need to test it. And I do love a mathematical model, but I really love being out into the field and explaining this stuff to the barmaids and to my people who are joining these trials. You know, we tell them, you're getting an experimental vaccine. You got to come back. You know, we need to test you. But this is not an easy road, as we all know, and sorry for all the similes. But there's many, many challenges in developing a vaccine, and we have to keep this going. I do run a little bit on hope. I wake up happy. And on that note, I'm going to end with another quote by this great guy. His name is Tim Minchin, and he's just my new favorite Australian, who basically says that every mystery ever solved turns out not to be magic. We really can't model our ways out of looking for a vaccine. We actually have to test the vaccine, and I want to thank all of these people for making that happen, including the NIH, Okairos, and the group at Oxford, who are now testing a vaccine, doing some phase 1 testing in HIV positives. but Andrea Cox at Johns Hopkins, and now Paula Lum, who's running things at UCSF, and the NIH for supporting it. Thank you.